Okay, oh, there we go. Okay, well, thank you for joining us today. Today, I'm here with Dr. Shireen Lim, who is a dentist and someone that's been writing and publishing and educating people about the connection between breathing, sleep, and growth and development of the jaw and the teeth for some time now. It's an area that I'm really passionate about, and an area that she's done a great job in defining how parents can understand the impact that sleep, breathing, and growth and development has on a child's dental arch, but also their overall health as well. Dr. Shireen, thank you so much for joining us.
No, thanks very much for having me. It's really great to reconnect after so many years.
Yeah, we were just talking before that the last time we actually saw each other in person when we met was in 2016 at a conference in Chicago on the topic that we're about to talk to today, of which you have published a book since that. And yeah, so there's a lot happened since the last time we talked, but it's been 8 years, hasn't it?
Yeah, no. And what's really funny is that when you published your book, that's when I started, and I was just saying how long it took me to actually get mine off the ground. So I really appreciated your very early support and sort of advice on making sure that it was very relatable. And yeah, I love what you have done since then, and I aspire to really get out in front of the public as much as you have.
Well, it's a challenge because, as clinicians, we kind of have the body of evidence kind of behind us that we want to kind of build the rationale as to what we're telling people about, but then getting that into a kind of condensed and easily digested form is quite difficult, isn't it? It's quite a challenge to do so, and you did a great job with your book.
Yeah, there was a lot of coaching involved.
Exactly, a lot of pain, but it's worth it in the end. I'd love to hear about your kind of journey into, your first steps, changing from a regular dentist, maybe looking into sleep dentistry, and what kind of prompted that? What were your, first kind of, ways looking at, the mouth differently?
Yeah, well, I was initially prompted to look into breathing because of my husband's snoring. So that was driving me pretty crazy. And I decided one night, out of frustration, I was going to Google up dental sleep appliances that help adults with snoring and sleep apnea. And I wanted to be able to help solve this problem for other spouses because it's pretty frustrating. And I enrolled in Australia's first postgraduate program in dental sleep medicine. And I learned all about dental sleep appliances and snoring, sleep apnea, and became involved in the team management of this for adults. And what I actually started to question is, why are we doing this Band-Aid solution to compensate for poor jaw development? Why don't we grow jaws better while children are still younger? And along that time, I came across Dr. Christian Guilleminault's work on palate expansion in children and how effective that was in helping to alleviate obstructive sleep apnea. So I decided I was going to learn more on early intervention with orthodontics. And I went and enrolled in Dr. Derek Mahoney's program and learned orthodontics through many other teachers along the way. But I also met Dr. Christian Guilleminault in 2014, and I told him, you know what, your work has inspired me to go down this path, learn about orthodontics. And he said, if you're doing palate expansion, you're too late. So I had no idea what that meant, but I really went further to find out that form follows function. And the jaws grow the most in the earliest years of life. And they're stimulated by the way that the muscles work. So we really must address and get the muscles working well during suck, swallowing, and breathing within those first 6 years of life to help promote better jaw development and in turn better airway and sleep breathing for life. And so that's how I became involved with tongue tie management, promoting breastfeeding, and getting children younger and younger so we can make more of a difference.
It's such a big problem, isn't it? And you've kind of gone through a whole age group that we can be addressing things from a very young age, but then also too, you started by seeing this problem in adulthood with your husband and the problems that we see with sleep apnea, which is a very significant problem in society. Not only just from partners hearing their partner snoring, keeping them up. It's over 1 billion people on the planet diagnosed with sleep apnea. This is a significant issue, and then all of the evidence behind that as to the damage and the health issues that associate with that. Would you say that since starting your kind of awareness into sleep dentistry, that there has been a growth in awareness as to the importance of better sleep breathing, or do you feel like we need to increase that awareness out there in the society?
I think there is more awareness of it, but in general, we need to promote more awareness, because when we don't breathe well during sleep, it affects every aspect of our life. And we know that there is increased risk, like for instance, in children with ADHD type of symptoms, or with adults, increased risk of virtually every chronic health condition, heart problems, reflux, depression, and yet many people are medicated for these problems and no one's really addressing the underlying breathing problem. So yes, I do think there needs to be much more awareness of it. And not just that there needs to be an integrative team approach. It's not really one discipline or one field that can solve the problem. It's a very multifactorial problem. And so, yeah, there's a lot more awareness to go.
That's a great point too, is that the awareness between practitioners and the communication and teamwork that is required to kind of complete this picture is very important. And sometimes that disconnection is hard for patients that get stuck between. And so that's definitely a big part of what I see as being an awareness that is needed, that clinicians need to also become better educated in the importance of sleep breathing, but then the dental presentations and so forth. What would you say is some of the earlier presentations that for instance, a parent could start to see in a young child with sleep breathing issues? What are parents experiencing today, and how would you say that this is, being addressed by their, maybe their pediatrician and so forth?
Mm-hmm. Yeah. So going back to that original topic, Stephen, the other problem that we see is there's so much focus on obstructive sleep apnea, which really is an end-stage problem. You have to meet a certain criteria of how many times you stop breathing per hour of sleep, for how long as well. And you really have to reach the end stage of the problem. But the thing is that the problems begin when mouth breathing starts, and then we develop snoring, and then we have upper airway resistance syndrome, where we don't actually stop breathing for 10 seconds or more. And instead of doing that, we're just working super hard to breathe, increased efforts. So it's actually a lot of work, but there's an increased stress response, and sleep is not restful. It's quite fragmented. So we've got to recognize that whole spectrum of disorders and really understand that for healthy breathing and sleep, we need to promote nasal breathing. And so what are the problems that we recognize in children? Well, anytime a child is mouth breathing, that is a concern. We want children, when they're sleeping, to look still. They shouldn't look effortful, like they should be not sweating at all. They should be quiet. Any sounds that they make is a sign of increased resistance to airflow. And yeah, we want them to have their lips sealed. So other key red flags that there are problems are snoring, gasping, tipping their head back during sleep to help open up the airway, any tossing, turning, sweating, teeth grinding, bedwetting, and feeling like unexplained awakenings or feeling unrefreshed on waking. So during the daytime, this will present as poor attention and concentration or hyperactivity, difficulties with emotional regulation or feeling quite tired. So there's some of the things that parents should look out for.
As a parent, do you kind of look back a little bit as to some of the signs with kids breathing that perhaps were that sometimes slip under the radar a little bit, or or maybe your friends that have had kids or so? Do you feel like there's a there's a lot of symptoms that kind of slip under the radar a little bit with kids and so forth that can bubble along to be a more serious problem?
Yeah, absolutely. Oftentimes when I ask people, how is your child sleeping? If a child is sleeping through the night and not waking the parents are like, yeah, they're a perfect sleeper. And then when we dig deep, we will hear all these other clues that they're not sleeping very restfully. But yeah, a lot of the time we don't look at our children during sleep, and they will display different symptoms during different parts of the night. So they may be more affected during deep sleep. So it may be different parts of the night that sleep will be disturbed. It's not necessarily teeth grinding and snoring all night long. It's just for periods that we have to be alert to. So yes, it's really easy to miss these problems.
What would be your advice to tired parents out there that has a child that's sleeping, but then they've got an inkling that there might be an issue? Would you say that they should kind of make a schedule to look at how the child's sleeping, or what would you say is the best approach for that?
Yeah, I would say that it's important to observe your child during various portions of the night. and maybe even the second half of the night, maybe when they're most vulnerable. And if you see anything unusual in terms of any snoring, restlessness, head tilting back, it is important to see if we can take a video of that to support this and make sure that this issue is not dismissed.
Yes, and sometimes we've found that night recorders can be a good way to do it if they're struggling to find some kind of symptoms, or if they're presenting in different ways. You mentioned the diagnosis of obstructive sleep apnea. Now, this is a difficult, sometimes a difficult diagnosis to get even in adults, but there's quite a different, it's quite a different issue in kids, isn't it? Where the tests for sleep apnea are quite, they're designed for adults. Would you say that there's downfalls, and how do you work with sleep tests and so forth in your clinic with children?
Yeah, to me, I don't actually work with the sleep test. What I find in our community is that quite often the sleep tests, they're really only looking for obstructive sleep apnea. And quite often the child will get, the issue will get dismissed as the child has no problem. But we have to recognize that mouth breathing, it's important to have nasal breathing, because there's research to support that even mouth breathing children without snoring, without obstructive sleep apnea, there is an increased prevalence of ADHD type symptoms. It does play out on their behavior. And even snoring without sleep apnea, we know that there's increased risk of developmental problems. Quite a large study of 10,000 plus children has actually shown snoring. There's an association with losses of grey matter. So I think that for me, it can be problematic when people come in and they bring their sleep study, no sleep apnea, we can't do anything for you, yet the parent actually experiences that a lot of difficulties with their child and these breathing problems. So I'm not going to overdo the sleep study. If I see a risk factor there and a child is not functioning well, I'm okay to address the risk factor, whether it be a narrow palate or open mouth posture or a tongue tie. I think that it's important that we address each factor individually.
We'll definitely go through the functional oral assessment. I'm just trying to work through the problem point that some people get stuck with. They get they see there's a problem and they go to maybe a pediatrician or maybe an ENT surgeon, and they're asked to do a sleep test, and then the sleep test comes back negative for their child, and they're stuck still thinking that there's an issue. What would be your kind of advice there for both clinicians and the parent?
Yeah, and even sometimes when there is a diagnosis of obstructive sleep apnea, the way that the medical world works is that people are considering adenoids and tonsils. They're looking at surgery. If that child has had a surgery, what next? We can offer CPAP, positive pressure, to keep their airway open. But there's not enough integration. We have to consider that the jaws play an important structural role in our airway. They form the outer limits, or the airway support, the floor of the nose, the space for the tongue. So it really is important that we have a look at those. And I think a dentist can be a very helpful person, a dentist who is trained in airway, because they can assess those factors and they can look at things like tongue ties or how the mouth is working, because the tone, how well the lips seal, how well the tongue sits, all those things can have an impact. So I do think a dentist that is trained, or even a myofunctional therapist, they're really good people to start with, to look beyond the normal way that children are managed in general.
Absolutely. And I'd like to kind of just try to define a little bit, so for people that are unaware as to what this kind of area, what we look at when we see a child like this, because obviously for us it's very obvious because we see this all the time, but there's a lot of people that aren't aware how to identify these kind of signs in kids. So let's say a 4 or 5-year-old walks into your practice. How are you assessing them? What are you looking at when you're considering this assessment for sleep breathing?
Yeah. Well, their general demeanor, how calm they are, whether they can sit still. A lot of kids have a lot of trouble sitting still, and that could be a sign of overtiredness. And then just looking at their facial profile. There are certain facial profiles that are actually more indicate a greater risk of sleep disturbed breathing. So for instance, if we have an open mouth and a longer face, narrower face, that could be one profile, or the receded lower jaw, or even a mid-face deficiency where the top jaw or the whole face hasn't developed properly forward. These are all things that I look at when I first even look at a child. And then when we look inside the mouth, we're having a look at, how crowded is their throat? Can we see the back of their throat, beyond their tongue, or what we call the Mallampati score? Can we have a look? Do they have obstructive tonsils? Are they breathing okay easily through their nose with their lips sealed? What is their jaw development like? Is there any spaces between their baby teeth? Because any lack of spacing could indicate an underdevelopment of the jaw. And what is the shape of their palate? Is it V-shaped or is it nice and broad and U-shaped? I look for things like teeth wear, because tooth wear is one of the strongest red flags that a child might not be breathing well. And looking at the tongue, can it move well? Can it lift well? Does a child, are they able to coordinate their tongue tip to the roof of the mouth and say N without their tongue thrusting forward? There's some of the red flags that I'm looking for when I'm looking at a child.
And it's such a detailed and complex area, isn't it? The growth and development of the jaw. Mm-hmm. There's so many inputs, and that it actually goes back very, very early. You mentioned at the start that you now consider, kids from a newborn age and their breastfeeding journey. What is some of the common presentations that you see and the difficulties that mothers are having with children that are born now that can't breastfeed very well, and what are some of the oral function issues that are associated with that?
Yeah, when children can't feed well, we want children to have a good deep latch, so they should be able to form a really great seal around the breast, and I'm often dealing or managing tongue ties. So they're the tight attachment that connects the floor of the mouth to the undersurface of the tongue. And when this doesn't allow the tongue to lift properly, what this can present as is difficulties with latching, poor drainage of the milk as the tongue's not really able to suction really well, or painful nipples or pain during feeding, children pulling on and off and on and off, or they're sucking in a lot of air. And so this can present as reflux-like symptoms where they need to be held upright, or they have spit-ups and, vomiting, or they're just very uncomfortable and gassy. And a lot of these children may be medicated for reflux when the reality is that they're actually swallowing air and taking it in too much, and that's creating some of their symptoms. So there's a lot of these feeding issues that present, and quite often the tongue tie is overlooked because none of us as dental professionals, or even speech and lactation and ENTs, we don't necessarily get a lot of training in this area. So it's quite common that people will have multiple opinions and get it dismissed. And I think that it's really important to recognize breastfeeding. If we can do it, it sets up the mouth for better oral function for the rest of your life, and it really plays an important role in how the jaws develop. So if we can get that feeding right early on, or if someone wants to breastfeed, it's really worth getting a good lactation consultant who understands these issues to see and make sure that there is no tongue tie.
That's one of those important multidisciplinary relationships, isn't it? Early on, especially when mothers that can have a lot of trouble with that early breastfeeding journey. It can be quite difficult, and that support and that kind of identification, as to if there is oral restriction contributing, and then getting to a practitioner that may be able to help is an important kind of link in those first couple of weeks, isn't it? And it can be a bit confusing. In some countries, they're actually set up to do this in the hospital system, aren't they, in South American countries? But it's a little bit disconnected in Australia and the US, and it's sometimes a little bit hard for people to find those kind of practitioners. Would you say that's right?
Yeah, absolutely. We see children that they may have seen up to, 12 plus practitioners with very significant issues. And someone like a pediatrician might have checked the baby at birth and said, oh, there's a tongue tie. It's mild. don't worry about it unless you're having feeding problems. So it sort of gets downplayed a little bit. And then in the meantime, when they're suffering problems and seeing all these various professionals, they've forgotten about it because it was not really weighted properly at the very beginning. So it's very confusing for parents. I see a lot of very despairing situations, and I do believe that we all need to promote better screening and awareness of this amongst healthcare professionals.
What are some of the differences that you see in a baby that has a significantly oral tie that is affecting their feeding? What are some of the changes that the mother and sometimes the baby experience?
You mean post-release?
Yeah, pre and post release. Like, what are the symptoms and what are they experiencing once they do have a release? In your experience?
Yeah, I think individual results can vary because it's never just the tongue tie that can be contributing to the problem. There may be low tone or maybe body restrictions where a baby is not really comfortable. They've got a tight neck, which is all connected to the tongue as well. And that can affect the way that they feed and the way that they position as well. So it really is important. I cannot say that every single baby will have exactly the same outcome. But generally speaking, yes, a lot of them, if we work really closely with other practitioners like lactation consultants and body workers who can provide the physical therapy or the manual release of the body tissues that are restricted, yes, we will generally tend to get improvements in feeding, improvements in latch, less sucking and swallowing of air and this reflux-like symptoms. And in many cases, some children, they don't really need those reflux medications and can be weaned off them. And, some of the most satisfying ones are the parents that walk in the next week and I've got a different baby. My baby's chilled. They're really highly stressed. Feeding's not going well. Baby's so upset. They're not getting any sleep. And all of a sudden they've got a baby that they can enjoy. And also feels more comfortable in their body as well. So there's a lot of variation in the results.
Some of the benefits that a baby may receive is this kind of the release of the tongue and the movement of the tongue and connection to the palate. Can you help people to understand what the role of the tongue is in one, widening the palate, but also in feeding, how this relationship works in order to both help the child feed efficiently, but then also to guide their growth and development?
Yeah, well, so for optimal transfer of milk from the breast, it requires tongue suction. So what happens is the tongue has to press that breast tissue up against the roof of the mouth, and then as it drops, it creates a suction, and that's when milk comes out. And because the breast is nice and soft, as the tongue lifts, it just sort of molds the palate broadly. And so sometimes breastfeeding is referred to as nature's palate expander. And this is in contrast to bottle feeding, where we have a nipple, artificial nipple that's not as compressible, and we don't really require as much tongue effort. We can actually use our cheeks to suck, lips and cheeks to suck the milk out as well. So it doesn't really develop that tongue as well. Sorry, what was the second part of the question, Stephen?
So the connection of the tongue to the palate is key for the baby to learn, to properly and efficiently develop and feed. But what is the connection then moving forward between the of the tongue and the palate in growth and development of the jaw as well?
Yeah. So how does that tongue really grow the jaw? Well, because the baby's their jaw is the most moldable in those early years of life. The first year, it's the most moldable. And so whenever we promote breastfeeding and optimal suction and optimal latch, that tongue and that breast tissue is going to mold that palate broadly. And that's important because that palate is really the floor of the nose and the space for the tongue. And so realistically, in those type of cases, what we want to see is that the shape or the concavity of the palate is more or less the same shape as the convexity of the tongue, so that the tongue and the palate should be the same fit, very much like the brain and the skull, they grow together. And that's how it impacts it. And then when we're developing that good suction, we're just developing that really good tongue tone, because at rest, when we're breathing, our lips should be sealed and our tongue should be lightly suctioned to the roof of the mouth. And it's really important what our muscles are doing during rest and breathing, because that's where we spend the biggest portion of the day. And if we can develop that good tongue suction at rest during nasal breathing and all throughout the day, that's really going to help further promote good jaw development.
It's a connection that most maybe they're not so aware of today. The child's tongue should seal to the roof of the mouth, and it's something that it feels like it should have been innate, that kids maybe should have naturally kind of learned to do this, maybe through breastfeeding or early postural habits. And then for some reason, a lot of kids today, they just lose this, don't they? They don't have this ability, and they seem to lose the muscle response for the tongue to properly seal against the roof of the mouth. For parents, you mentioned myofunctional therapy, and this whole space is about understanding, strengthening, and teaching that tongue to seal up to the roof of the mouth. Can you explain what myofunctional therapy for the tongue is, and how this relates to this connection between the tongue and the palate?
Yeah, sure. My functional therapy is really training to promote awareness of better habits and to actually restore normal functions. So we want normal rest posture with tongue to palate suction, lips sealed without strain, and nasal breathing. And we want to improve swallowing. So we want the tongue lifting up, and we want minimal activity of the facial muscles as well. So we're really promoting that oral rest posture, but also improving the muscles and how they function during speech and chewing and swallowing as well. So there's a lot of reasons why things can go wrong, as you mentioned. Like we introducing a lot of bottles and soft foods where children aren't chewing really well, and also with the use of pacifiers. When we talk about that tongue to palate suction, one thing that can really alter that is the use of pacifiers. So they lower the tongue posture, and they actually alter swallowing as well. So we have these inward pressures of the lips and cheeks that can actually distort the palate. And a lot of parents think they just use it at nighttime only, but the trouble is when a child's jaw is so moldable and a baby sleeps most of the time, that is going to create a significant issue with the jaw development.
What would be your recommendation for a parent with a baby and the pacifier? What do you tell parents to? Because obviously pacifiers can have some use, obviously in those early days. What are your guidelines when you see patients using pacifiers?
Yeah, I believe that a lot of parents don't really understand the implications. So it's really important that we educate parents, because even as a dentist, I didn't even really understand this when my oldest, was young. I actually used a pacifier. I didn't really think anything of it. I thought, I understood they caused orthodontic problems, but I wasn't actually familiar that it altered the way that the mouth functions and how the actual palate is growing. And so I think it's important, first of all, that parents understand this so that they can make a fully informed decision. And we want to soothe and remove where possible. So where possible, take the dummy out. If a child is not really unsettled, they don't really need it during that time. We really want to minimize the frequency and duration of use. And sometimes a lot of the babies that are they're very reliant on a pacifier, I actually find a lot of these patients, so a lot of the babies that I see, they're sucking and swallowing a lot of air, and they're having a lot of discomfort. And these are the babies that may be having tongue tie. And so sometimes when I address that, we can actually find that a baby's more comfortable and settled, and they don't actually need to have the pacifier. And probably the only one type of baby that I might be more concerned about is those babies that really, they have very disturbed sleep, and it's more continuous with the pacifier in. That might be one baby, and these might be the babies that might be more prone to flopping or more comfortable sleeping on their stomach. Sometimes there are a few babies that kind of need it to help create the suction to keep that tongue and soft palate connected, and it helps with their breathing. So that might be the only real one baby that I think, there may be value.
Sometimes in the dental chair, we can identify, pacifier or extended pacifier use pretty simply, with certain bite relationships. This kind of moves into the relationship of the pediatric dentition, the kids' teeth, and the bite as a child grows and develops. And some of the problems that can pop up in the early dentition that are sometimes a little bit more subtle than orthodontic problems down the track. What would you say are some of some of the things that parents should be looking at in their child's bite in these earlier stages that might be red flags for functional issues like extended pacifier use?
Some of the red flags associated with pacifier use.
So for the bite issues, so what are some of the early bite issues in the pediatric dentition that
Okay.
parents can identify as problems, as maybe a jaw, for example, as a pacifier, extended
Yeah.
pacifier use?
Well, definitely when children are in their baby teeth, they're supposed to have gaps in between the baby teeth because the gaps are there to preserve space for the adult teeth to come through. So when we see a shortage of gaps, a lot of parents think their child's smile is quite beautiful. However, this is a severe dental crowding problem waiting to happen. We also want to see all the top teeth fit on the outside of the bottom teeth. So anytime we see that there's a crossbite or even what parents would call an underbite, that could be an indication as well that the palate is not growing properly. Or when we have a deep bite, when there's quite a deep overlap between the top and bottom teeth, if the child is biting together and you cannot see the bottom teeth. That could be, I usually think of that as a symptom of low tongue posture or the back of the tongue not really working very well. And what happens in that situation, that bottom jaw is trapped and things can't grow properly forward. So there's some of the common bite problems we see. And sometimes just looking at children as well, the teeth should more or less be straight in a vertical orientation. And if we have a dummy user, a pacifier user, what we'll often find is the teeth are tilted in. So it kind of looks like... Sorry, Steve, help me out here. Stephen, help me out.
So the tilting of the back teeth, yeah. So if you look
so the bottom teeth look like this.
Yeah.
And the top teeth look like this.
Yeah.
Yeah, instead of straight. And that's usually a reflection of the tongue not working well, and a child's had altered swallow where there's inward pressures of their lips and cheeks and everything is getting quite constricted.
Yeah, and those, those signs are often a little bit harder to pick up, aren't they? Or parents are probably much less aware that you can have these early orthodontic issues pop up where you can see that there's a problem, like you said, with teeth that aren't spaced very well. That's a very, very common presentation we see now. And the child has a lovely straight smile. They've got a lovely smile, but then, as a dentist who's thinking about their growth and development, we're starting to identify that, hey, we need to get this jaw growing because we've got huge adult teeth coming in, and we've got to get this jaw bigger, or they're going to have a big problem. And then what are the reasons behind that? How they're breathing, how they're using their tongue. And so it's a really kind of important space for parents to be aware of, isn't it, where we can start to see these early signs so that we can help a child grow and develop, and maybe identify a functional problem that could help. In terms of treatment of these kind of issues, traditionally we've thought maybe that we wait until the adult teeth come in before orthodontic intervention is made. Would you say that there is an earlier age group now where we should be considering treatment of these kind of orthodontic issues?
Yeah, the traditional age is 7 to 8 years, and I believe that some children will benefit from this earlier. I was treating the 7 to 8 year age group, and then I'm finding, some of these children, they're sleeping well, they're breathing better. Why do we have to have a cutoff point? So one of the very first children that I treated below 7 was actually my daughter at age 6. She had her adenoids and tonsils out, and there was still some symptoms of disturbed breathing, and I wanted to do what I could do to help her. And yes, so I did the palate expansion for her. And then as I've gone I've treated younger and younger. Dr. Kevin Boyd, one of our colleagues in Chicago, he said, it's kind of like a child that can't see very well. You don't wait till they're a certain age and tell the parents you're going to save by not having to change glasses every year as they grow. Because if we wait, what experience is that child going to be missing out on? If children don't get good sleep and breathing, they're so vulnerable during those early years of life where we have a lot of development going on. And we know that there are so many risks associated with disturbed breathing and sleep. And these risks, children may be at the greatest risk around the 30-month age group, because that's a critical window of brain development. And I'm not going to do expansion for a 30-month-old, but I don't think we need to wait until they are 7 to 8 years.
The risks and the problems associated with breathing issues is quite well published now. The evidence is quite compelling. The effect of treatment on kids in these stages probably is a bit less published, isn't it? It's a little bit less known, the literature associated with the benefits of intervening. What would you say are some of the papers that are showing us that there can be benefit of treatment in these early stages for these sleep issues?
Yeah, you're right, because a lot of the work is actually done on older children. So we actually have to apply that rationale and really sensibly to apply it to our younger children instead of waiting for big research papers. But one of the most significant papers, and really this was one of the inspirations for Dr. Christian Guilleminault to explore palate expansion as an option for children with obstructive sleep apnea, was a paper done from Perth, right here where I live, by Lindsay Gray, and it was a case series. It was consecutive 310 children that were treated with palate expansion. Now, it wasn't for orthodontic reasons. It was actually targeted to improve nasal breathing, for instance, with children that had asthma, deviated septums, or recurrent ear infections. So a lot of medical indications, not to do with the teeth, and they treated children from as young as 4. And ultimately, I actually met with the orthodontist a couple of years ago, aged 92, and he actually told me that they had treated 2,000 children in Perth for this, and they were receiving a lot of medical referrals because the orthodontists were not very on board with it, but it was actually really impactful. They were noticing improved concentration, attention, even eating, things like that, when children could actually have improved nasal breathing. So, 90% of children were going to have a conversion to nasal breathing with this intervention. So, yeah, I think a lot of people, they want to see these randomized controlled trials where we have children that have treatment and no treatment, and it's very difficult to manage. And the other problem is that it's really never one solution that fits all. We have to think, if there is a narrow palate, it is by definition a narrow nasal floor, reduced nasal airway, difficulties with airflow. So why not intervene with that? There's really minimal risk in my mind about doing this treatment. Yeah.
And you mentioned Christian Guilleminault, who really established the sleep kind of breathing interface at Stanford Medicine. Since then, there's been a whole kind of research arm kind of inspired by his work, hasn't there? In terms of, and it has kind of been centered around sometimes palatal expansion and so forth. What are the more kind of recent papers that you've seen that has really kind of driven your practice in terms of palatal expansion and benefits for the airway?
Yeah, I mean, there's now multiple systematic reviews and meta-analysis to support palate expansion can be an effective treatment intervention to address or alleviate obstructive sleep apnea. So that's really important. I think there's been some really great ENT side papers where looking at outcomes like, for instance, when children have glue ear or recurrent ear infections, and then it's associated with hearing loss. So there's research to suggest that palate expansion can actually improve those type of symptoms as well, because what happens is when we widen the palate, we're getting all those soft palate to have better support, and it can function better during swallowing. And when we swallow well with the soft palate lifting, that helps to open up the eustachian tubes, so we can get better drainage of the ears. And so there's actually one paper that randomized children into that, like having palate expansion, having grommets or a surgery to place a tube that can drain the ear, or no treatment. And what they found was children with grommets and palate expansion, they both actually had improvements in conductive hearing loss, and they were both equally the same. So if a child has a narrow palate, that could be a more targeted intervention to avoid a surgery. So these type of things make me think that really there is a lot of benefit. Even recently, there's been a few papers about the link between speech sound disorders and malocclusion or narrow palates. So I believe that there's a lot of functional reasons why we should consider palate expansion beyond the teeth. And they're really the papers that drive me, because what I notice is that when I do the palate expansion for children younger and younger, there's actually a multitude of benefits, and it really improves the face. But the other thing that really drives me as well is the great work that's being done with adult palate expansion. Particularly, I'm a big fan of Dr. Stanley Liu, who is an ENT maxillofacial surgery surgeon, and he's done a lot of research, really great research, to help paint the picture or establish that palate expansion or certain protocols can actually help achieve the results that are possible in children. However, it's a little bit more complicated, and it will involve a little bit of surgery often. And so that type of thing, to really drive home the fact that this palate, it really has a key role, having a good palate has a key role in improving sleep and breathing in adulthood. That also makes me want to treat earlier and earlier, because it's so simple to do in a young child that is growing. We don't have to do a surgery, and we can set things up and help them experience better sleep, breathing, and development in all those decades in between.
You summarize it so well, and so does your book, by the way, which we'll talk about in a minute. But the evidence has been mounting for why we should be looking at this earlier, and then the benefits that flow on. It's such an inspiration for that some of these people that have really pioneered a lot of this work, isn't it? That that they've shown that and really kind of established that the evidence base is there to for us to consider this treatment. And you mentioned that there's a lot of crossover in the literature between ENT papers and the airway and palatal development and so forth. What do you feel is the interface in a young child between a dentist and an ENT in terms of where should the decision trees be made, and where should parents be going? Because often parents get a little bit stuck between, do you feel, the surgeon and the dentist or the pediatrician. How do you feel that interface works?
Yeah, ideally you need to work with someone that actually they have a referral back and forth process with someone, and it's just not a one-way type of referral process. Because a lot of ENTs, they don't necessarily get taught about the jaw structures, and they're really focused on what they do. And as dentists, we're focused on what we do. I actually think that as dentists, we are probably more likely to refer to an ENT. So oftentimes a dentist could be could offer a broader picture, but there are definitely some ENTs that are quite open to it. And also, while we're on this topic, Stephen, you had mentioned what are the most significant papers that have guided me. You're probably familiar with Dr. Audrey Yoon's most recent paper on palate expansion and the shrinkage of the size of the adenoids and tonsils. And so that's another paper. I mean, it's only one paper, but they actually were able to measure the size of the adenoids and tonsils in a group of children that had palate expansion. This was during COVID, when they didn't have access to surgery, and they actually found that there was a reduction compared to children that had no treatment. And with this reduction, it was associated with a decrease in symptoms of disturbed sleep. So that's something else that I think maybe sometimes some children won't actually need to have a surgery procedure, and maybe doing palate expansion will help offer enough relief to actually alleviate the symptoms, and then we can focus on other things, whether it be training a child to close their mouth. So what is the interface? For me, if a patient walks into my practice, I'm going to look. If they've got obstructive kissing tonsils, that's going to be a referral to an ENT straight away, because they're going to have a harder time tolerating my treatment. If a child can close their lips with a paddle pop in between their lips, Surusagi's studies showed that this might be a child that you may want to focus first on closing the lips and doing myofunctional therapy. Or if there is a very narrow gutter palate, and I kind of know that if the child has surgery, they're still going to have problems. So I want to address the palate first. I want to do the least invasive treatment. If I can get in and out in 6 weeks, I want to reassess and see what's possible. So,
no, that makes sense, and you're kind of describing, sometimes with the severity of swellings in the back of the throat and the nose, the adenoids and tonsils, that surgery is necessary, and that the dentist, and in particular, can build a really good referral pattern with an ear, nose, and throat surgeon. I know in our practice we have a great relationship with a surgeon that there's some situations where we feel that surgery is necessary, and some people do get stuck between clinicians and not really kind of getting a solution for a child that's snoring very heavily. And so in severe situations when there are very swollen tonsils, that's where a fast and kind of clear referral to an ENT does become quite a use. So I think that's what you're describing, this severity of the issue, sometimes requiring surgery and then going through a development process. Is that sometimes how it works in your clinic?
Yeah, definitely. Because if a child has obstructive tonsils and they're not going to be chewing or swallowing well, and then I put a plate inside their mouth, they're going to not cope as well. These are the child that is going to play and flick and use their tongue to flick this plate out and create a lot of drama for me. So I know that I'm going to have a better result if that is cleared first, and then they will have some sort of improvement, and then we can address the other risk factor.
And then on the other side of the equation, the kids that are just sent in for surgery without any other kind of dental or airway assessment, they sometimes the parents may be of the perception that the problem should be gone, but then the child is snoring again in 6 to 12 months. What would you say for parents, in terms of kids that are had or having surgery, when to start thinking about, seeing an airway focused dentist?
Yeah, well, it is my, I tend to think that those children that are having surgery, enlargement of adenoids and tonsils, that's a symptom. And children are not going to be cured by that, because often they'll have persistent mouth breathing or snoring, or it will come back down the track. So I think that it is important to rule out all those other risk factors. And I don't know if you're familiar with the work of ENT plastic surgeon Howard Stepak. And he's published a whole book and hypothesis that enlargement of the adenoids and tonsils, rather than them being the cause of the breathing problem, actually the breathing problem could precede that. And it's related to having some sort of subclinical deficiency in the palate. And so when we have a narrow palate and we have increased resistance to nasal breathing, we're going to have to breathe harder. And it's going to generate these negative pressures. So our throat is going to collapse, and this pulls in the tissues, the adenoids and tonsils, and that can actually contribute to the enlargement of the tissues. And that can be really helpful in explaining why after adenoid tonsillectomy, a lot of children end up having these problems again. So yes, I think it's really important that we understand we need to check for the jaw structures. And what age should we do it at? Well, how early does that dentist work with children? There are some dentists that will work earlier, and maybe it's worth seeing them earlier, not necessarily starting treatment. That can be weighed up, but the earlier we have to assess the situation and work out a plan for the future, it just really opens up more options.
And we mentioned myofunctional therapy before in terms of its focus on the tongue seal to the roof of the mouth. But part of that as well is that, a lot of kids that have these, narrow airways, swollen adenoids and tonsils, is they develop this dysfunctional breathing pattern. And then there seems to be this, the journey they have to go on to learn to breathe again. Which the dentist really kind of can be a part of, because if we can redirect them from the mouth to the nose, sometimes they need that prompting in those sleep cycles, to keep the mouth closed. What do you feel is the link between behavioral breathing patterns and the airway, and getting this child to breathe better as well?
Oh, I know that you spoke to Dan Hansen recently, and he would probably be more expert at this. But definitely a lot of children, they're over breathing, they're very shallow breathing, and they're not using their belly or diaphragmatic breathing. They're more using their upper chest. And so, yes, I cannot say that I'm the best expert at this, but sometimes having some sort of breathing retraining is really important link, in addition to ensuring the palate structures and the child can close their lips. We need to train that. And Yeah, I would say probably refer to Dan.
Yeah, well, that's right. And so it kind of it shows that there's this kind of growing interdisciplinary
Mhm,
team, right? Like where
mhm,
we're certain, there's these breathing practitioners and mindfulness therapists and so forth that focus on different aspects of how
mhm,
the mouth and the breathing system works. And and your book particularly really kind of outlines all of the different researchers that define how all these people are thinking to get this child's
mhm.
mouth to grow. It's such a fascinating area and such a complex area. As we've said, your book, really does summarize a lot of it, very simply for parents. So I really highly recommend. Can you tell us a little bit about that and where they can find it?
Yeah, for sure. And I also just want to leave a take-home point for parents as well with the whole breathing thing, because within our practice, yeah, we will use like the breathing apps and just getting children to practice the diaphragmatic breathing. There's quite a lot of videos on YouTube that can help out with that. So it doesn't have to be overly complicated, but when children slow their breathing and focus on that belly breathing, gosh, they're so much calmer. And it can really help children get to sleep. So that's something to look at, which is simple. But yes, in terms of my book, I really wrote the book because when I started to change from general dentistry and offer more early interceptive orthodontics, it's quite foreign, it's quite new, and I have to try to explain to people why I'm doing this. And it's different from what your other children have had in the past, and why there could be a whole connection between the whole sleep and breathing. So I needed a way to convey the information without having to do extended consults. And so, really, the book is about explaining the importance of healthy jaw development and healthy sleep and breathing, and what are the red flags along the way from the first days of life. What are the red flags that things are off track, and what are the various strategies to get children back on track? And so, probably the easiest way to get the book is really through Amazon. Yeah, it's available in so many countries via that.
And it's called Breathe, Sleep, Thrive, isn't it? And
Yeah.
it really does kind of summarize well how impactful this kind of treatment and this awareness can be for, both for parents, but also clinicians as well. I think we could both agree that it's changed our professional life so much to, really bring, meaningful health change to patients. Would you say
Mhm.
that's right?
Yeah, definitely. I'm so thrilled with the book having, uh, the primary audience as parents, but then it's been picked up by many professionals who actually then, buying in bulk or sending it to referring practices or other people that they want to get on board with the idea that airway health is important and we need to work integratively.
Exactly, and it can really help, those early times where parents are getting a little bit stuck between clinicians. Having those people that are aware of these kind of issues and how to kind of refer and how to identify these problems early.
Mhm.
You're also holding a conference for professionals on these areas, aren't you? In Melbourne in August. Can you tell us a little bit about that?
Yeah. So this conference is called Inspiration by Integration, really about promoting healthy breathing, um, as a team approach. And so it's a practical guide to children's airway health. We've got now seven speakers, sorry, from various fields. So all of us are from sleep medicine, orthodontics, sleep surgery, ENT, myofunctional therapy, all the really key parts of the solving this problem. And we're inviting all child healthcare professionals. So at the moment, there's around 12 different fields, including physio and speech pathology, just everyone that's involved with children. And really, we're going to all be talking about it from our different perspectives, but all of us have a common goal that we need greater integration. And it's really going to be interactive. There's time for interactive or panel discussions. We want everyone to contribute and really, how can we move forward and promote more awareness and help more children get screened and get access to care. And so I'm pretty excited about it. Really top of the line speakers. I don't think that there is really a better conference for someone to learn more about it through so many different lenses. And that will be in Melbourne, August 30 to 31st. And
Yeah, I
yeah,
highly
I was just going to say, yeah, we've even got like people from different countries as well. So it's really open to everyone that really wants to be on the cutting edge of this and find out more.
Stanley Liu is going, which is a big opportunity to see him speak.
Mhm.
Yeah, I highly recommend any kind of clinician or anyone interested in this space, to attend that, because it's a big undertaking that you've gone, and it's a, as we've kind of talked about, it's a very big area, and we've kind of collate a lot of information, and then to have it all under one roof is very convenient for someone to kind of digest it all and really understand. So you've done a great service to practitioners to put that all together. So thank you for that. If for you also have a clinical practice too, do you want to tell us a little bit about your practice in Perth?
Yeah, I am based in Perth, and yeah, my practice is really restricted to tongue tie management from infancy through to adulthood, orthodontic wise, or I really work the best from around age 4 to age 8 years old. Um, and yeah, so I do that, and we offer myofunctional therapy. We don't actually see 1 to 3 year olds at the moment, and we do have quite a long wait. I think it could be about the 10-month mark, but definitely, yeah, open to inquiries with that as well. Yeah.
Well, Dr. Shereen Lim, thank you so much for sharing your work and all the work you've done to kind of bring this together for people to help parents have kids that breathe, sleep, and thrive. It's such an important area, and you've done a real credit to both our our profession, but also to help parents out there as well. So thank you so much for joining me today, and I hope to have a conversation like this in person very soon.
Yeah, no, thanks so much for the opportunity and for leading the way in terms of your book and promoting the awareness. Thank you.
Thanks, Dr. Lim. We'll talk soon.
Yeah, okay. Take care.